EKG knowledge base. And we're going to be focusing mainly on one lead, aVR, the Rodney Dangerfield of leads. And as a paramedic instructor and a critical care instructor now for almost 10 years, I always hear paramedics saying, leave out aVR. It's almost like an 11 lead. But we have to keep in mind that aVR can show us some really important stuff, and that's what we're going to be focusing on today's podcast. Oh, we go back to the beginning. All right. So lead aVR is our Rodney Dangerfield of leads. All right. So why did people stop carrying in the first place? Well, the whole myth was that aVR shows reciprocal information from other leads, so it's often ignored. It's indirect information. Well, that is crap. All right. Recent studies have shown differently, and we're going to talk about some of those, right? In a study done by Dr. Matu, who is EKG idol in Medscape, points out some very important things. ST segment in aVR is really a good sign of ominous coronary occlusions. It also shows that that patients with LAD occlusions, left main disease, and triple vessel disease have worse prognostic outcomes and require aggressive therapy. All right, so that means for us as paramedics that if we evaluate an EKG and we notice ST segment elevation in aVR, then we have to think, well, maybe this patient's having a left main coronary occlusion, LAD, or your triple vessel disease, which is your LAD, left circumflex, and involvement in the right coronary artery as well. And another study showed that if you have ST segment elevation in aVR greater than the elevation in V1, then that predicts left main coronary artery disease with an 80% specificity, and that is pretty impressive numbers. Right? Another study found that in patients with non-STEMI, patients, ST segment elevation of 0.5, a half a millimeter, a half a box, or greater in aVR was a useful predictor in triple vessel disease or left main disease with an 86% specificity. So is this something that we should really be looking at as paramedics, even though we don't really know how to read a 12 lead and people call us, stupid when it comes to 12 lead? Absolutely. All right. So we have to get our knowledge base up. Absolutely. We have to get our knowledge base up. Right. So this is a 39-year-old female. All right. Little case. She's complaining of worsening heartburn, history of myasthenia gravis. That's her vital signs right there. A bit tachycardic. Nothing much else. Minimal distress. Lung sounds are clear. Aspirin was given to her and nitro. Here's her EKG, and this is what we see. All right. So looking on this EKG from a standard paramedic student perspective, all right, we got no axis deviation. We see maybe some depression. All right. Skipping over aVR because that's what people tend to do. We got ST segment depression here throughout the precordium. Well, this is a non-STEMI. All right. This is a non-STEMI. We got some T-wave abnormalities, so maybe we're going to take the patient to the hospital of their choice, maybe even bypass a cardiac center. But if we pay attention to aVR here, we have elevations. All right? We have elevations there in aVR. People tend to skip that, and it could be an important predictor. All right? At the hospital, her troponins were 1.51. She was taken to immediate cath. All right? And she had a 90% occlusion of her left main with a 25% ejection fraction. So that little thing right there, all right, 0.5 millimeters or greater in aVR is a very good predictor, even in the absence of any other ST segment elevation, where most of us in the field wouldn't even call a STEMI on this patient. All right, some very interesting stuff. How about this 44-year-old male presenting with chest pain, chest heaviness, and shortness of breath? Here is the EKG. Again, looking at it, most paramedics would just be looking here for ST segment elevations. We don't see any, but if we look at aVR, all right, we have about 1 millimeter in aVR there, greater than V1, all right. This patient had a total proximal occlusion of the left anterior coronary artery without any other significant disease, with just this, just that, all right, in aVR, 1 millimeter ST elevation in aVR. So we have to look at it. We have to appreciate aVR. So beware. Respect aVR. Look for those elevations. Many studies have been done showing that elevation in aVR may be an ominous sign even without signs of STEMI. All right? But that's just one application of aVR that we can use. Obviously, it's the most important. All right? But there's other things that we can use it as well. Here's a 68-year-old woman 2 days after cabbage. All right, so here's your EKG. We're looking at it, right? Okay, we're looking at it. We got ST segment elevation in 1. All right, got some depression in aVR. A little bit here, a little bit here. So most of our medics would be like, I don't know what's going on with this. Okay, 1, really no 2 contiguous leads. All right, now keep that EKG in mind, right? But what do we call this? We call this pericarditis. And why do we call it pericarditis? Now, this is not a pericarditis lecture. All right, I have another podcast on that. But if we just look at aVR in pericarditis, and we think of the changes in aVR, right? In aVR, we're going to see ST segment depression, PR segment depression in all leads except for aVR. Oh, I misspelled and. Except aVR and V1, you're going to see PR segment elevation. All right? So going back to this EKG here, if we look, I'll blow that up. All right? We got PR changes. We have ST depression. Right? That could be pericarditis. Also, we noticed very minimal ST segment elevation throughout the entire precordium, right? And a very narrow J point to my R wave, which is also a nice sign of pericarditis. We also see PR segment depression here in 2. We also see it a little bit here in AVF. We also see it a little bit here in 1. All those are signs of pericarditis. But like I said, this isn't a pericarditis lecture. We're looking at aVR, and where we see ST segment elevation and ST segment depression. Good sign of pericarditis. So that's why we care. Let's look at this one. All right. Again, we have ST segment elevations throughout our entire precordium. All right, or throughout our entire precordium there. But MIs are isolated to a specific wall, to a specific location with reciprocal change. We don't see any reciprocal changes here. We see the notching of the J point, the classic notching there of our J point. But in aVR, we see a really elevated PR segment, ST segment depression, and it's really going to nail our diagnosis on pericarditis. Why is that important for us? Especially, look at this one here, notching of our J points, ST segment elevations. Oh, that looks bad, but it's not two consecutive leads there. All right, ST segments throughout the entire precordium, no reciprocal change. PR segment elevation, ST segment depression. This is pericarditis. We don't want to give this patient aspirin, do we? Right? If it's a bad pericarditis, we give the patient aspirin. We can give him hemorrhagic tamponade and kill him. All right? Maybe not so much with aspirin, but the TPA, absolutely. So we always have to be weary of these diagnoses in the field. All right? So look at aVR for pericarditis. It can help us out. Right? That's why it's important. All right? Let's look at this one. A 54-year-old woman, sudden onset DIB. And as paramedics, when we hear sudden onset DIB, we always think one thing. I'm not going to give it away yet. But we look at this EKG, and it's scary, right? Especially in the pre-hospital setting. We got an irregular rhythms, probably AFib. And we're looking at here, okay, we got some right axis deviation, right? Right bundle branch pattern. But that's all, per se in another 12-lead lecture. But here, we're looking at aVR. What I notice here about aVR is that it's upward deflecting. It's not downward. I got this upward initial R wave and a notching here, ST segment elevation in aVR. Right? So if I put all these together with my clinical picture of the patient, 54-year-old woman, sudden onset DIB, right axis deviation, right bundle branch block. We even have our S1Q3T3 pattern. We are thinking PE. All right. So if we look at the EKG findings of PE, it kind of tends to distort the electrical variance of the heart to the right. All right. So it's going to give rise to all these findings. You have that S1Q3T3 pattern in which you have your S wave in lead 1, a Q wave in lead 3, and an inverted T wave in lead 3 as well. But we're looking at aVR in this lecture, so our ST segment elevation at aVR and V1 is believed to be due to the right ventricular overload. We might be able to see that. We're also going to be seeing right bundle branch blocks. Okay. Now, per Dr. Smith, who is the, EKG god, T-wave inversions in the anterior leads are more common in PE than in MI. So look at your patient's overall clinical picture. All right. Now let's look at this. What do we got? All right. What do we got in this picture here? All right. Oh, sorry. All right. Looking at our EKG, we have a rightward facing axis. Looking at our S1, Q3s, T3s, right? Q wave in lead 3, inverted T wave, looking at aVR. All right. We have a little bit of ST segment elevation in aVR, terminal R wave pointing up, sinus tachycardia. It could be PE. Now, PE is very hard to diagnose based on EKG findings itself. And here's some numbers. 73% of patients having PE will have sinus tachycardia. Prominent S wave in lead 1, 73%. So those are your most common findings. Your late R wave transition, 56%. T wave inversion, 50%. Incomplete right bundle branch block, 20 to 68%, depending on what study you read. But the main part of this is that no significant findings are found in 20 to 24% of patients. So with our PEs, we have to rely on other criteria like Wells criteria and Perk rule and clinical gestalt in diagnosing these patients. Using our EKG, again, just as a tool in helping us diagnose. But those are our classic findings, all right? So let's take it home. What do we got? Well, here's got from EMS 12 Lead, one of the best websites out there for EKGs. But again, prominent S wave in lead 1, Q, T wave inversions in 3, right bundle branch pattern, ST segment elevations in aVR. All right, that's a good example of a PE. All right, S1Q3 T3s and elevation in aVR. All right, so let's look at this one. 39-year-old woman with a tricyclic antidepressant overdose. All right, so I kind of just gave you the answer with that. But this EKG is wide. That's the first thing we notice. It is wide. But we're not doing a tricyclic antidepressant overdose lecture. We're looking at aVR. aVR and helping us diagnose this. Now, what I see in aVR is a wide complex, very tall terminal R wave. All right, terminal R wave. The second wave up here going really high. And massive terminal R wave, wide complex, will help you with diagnosing tricyclic antidepressant overdose. Now, this is not easy, all right? What the criteria states that's very specific for tricyclic antidepressant overdose is a terminal R wave greater than 3 millimeters in aVR, wide QRS, long QTCs, all right, 400 and above. Tachycardia, you're really thinking tricyclic antidepressant overdose, all right? So, in Libet et al., in a study of 79 patients with TCA overdose, showed that the amplitude of the R wave, 3 millimeters or greater in aVR, and the ratio of the R wave to S wave in aVR are better predictors of seizures and arrhythmias in patients than the QRS interval alone of 100 milliseconds. And that's what's defined as our wide QRS complex is greater than 100 milliseconds or 0.10 seconds. All right. So this has studies backing it up. All right. Well, here's a test question. 35-year-old man brought into your emergency department following two seizures. His blood pressure is 75/40. Glasgow Coma Scale is 8. This is his EKG. You make the diagnosis. Now think of what we just talked about. Wide QRS, prolonged QTC. Look at our aVR here. Large terminal R wave, wide QRS, really supports TCA. All right. Now this test question was actually given as a test question. I think it was test question number 8. This is from lifeinthefastlane.com. This was actually given as a test question for the fellow of American College of Emergency exam. All right, and only 52 out of 81 physicians, working ER physicians, got this question right. So it's tough. So you have to use your EKGs along with looking at your patient for your clinical diagnosis in these patients. So the TCAs, here is what we're looking for. Wide complex, large terminal R wave here. This is saying greater than 3.5, but we can say greater than 3 millimeters. All right, that's what we're looking for. Wide QRS, large terminal R wave. All right, in aVR. All right, so practice makes perfect. Practice makes perfect. Now let's look at this one. All right. We're going down the list. Now, the first thing I notice here is that we have down, 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 which means this is extreme right axis deviation. I also look at aVR, which is the lead that we are studying about, aVR, and it's pointing up. Now, aVR should be normally pointing down. So we got to ask ourselves, why is aVR pointing up? So whenever you see extreme right axis deviation and an aVR pointing up, the next thing you should go to is your R wave progression. This looks like it has somewhat good R wave progression. So we see extreme right axis deviation, aVR pointing up, we have to start considering lead reversal. Right? So we can use aVR as an indicator of lead reversal. So in limb lead reversal, the P wave, QRS complex, and T waves are all directly inferior to the right, and the ECG has an appearance of the arm leads being reversed, and that's exactly what we see. But in lead reversal, the pericardial pattern, the R wave progression, is normal. Right? But aVR is positive, as opposed to this one. We still have extreme right axis deviation, down, down, down. We have an upward deflecting aVR. But look at my R wave progression. It's backwards. It's not going from small to big, right? It's not going from mostly down to mostly up, right? It's down all the way, and it's actually getting smaller, all right? So this is a backwards type of clockwise rotation of our R wave progression, and this means probably dextrocardia. Your patient's heart is oriented more to the right side of the chest rather than to the left. All right? So I'm going to have a complete opposite of what I would think would happen. All right? So dextrocardia and lead reversal, right? The P wave and the QRS complexes are upright in aVR. But in dextrocardia, the QRS voltage will gradually diminish as the electricity goes from V1 through V6. All right, so keep that in mind. The last thing I want to go over about aVR is the classic SVT versus ventricular tachycardia. Now, there are a lot of criteria in order to distinguish between SVT or VTach. None of them are absolutely 100% correct. I'm going to do a whole lecture on trying to distinguish between SVT and VTach, but the quickest way that I found to kind of do it is by using a certain type of criteria and by using aVR. And that's what this lecture is about, aVR. All right. So we look at this one, we print this out in the field, and we're like, oh boy, is this VTach or is it SVT? Does it really matter? Does it really matter in the treatment in the field? Some might say no, some might say yes. And if they're clinically unstable, then it really doesn't matter. Everybody's getting electricity anyway. So, but in order for us to be better clinicians as paramedics, we have to try to think about what might be going on here. So I'm looking at aVR. All right, I'm looking at aVR. The first thing that I notice about aVR is that it's pointing downward. We all know this why, but it's pointing down. So we can use that to our advantage. All right. This is actually SVT. This is a 15-year-old boy with Wolff-Parkinson's white. All right, a wide complex Wolff-Parkinson's white. Very hard to distinguish in the field, but we can use something to help us out, right? The easiest way that I found to do it was using Sasaki's rule, all right? In a later podcast, we'll talk about Pericardits criteria and Pericardits sign in order to try to distinguish VTach from SVT. But here's Sasaki's rule. It had 86% sensitivity and 97% specificity among 107 cases of wide complex. It hasn't been validated, all right, but it works. We're going to be using Pericardits later, but for today, we're going to be using Sasaki's rule, all right? So we'll use that. So in other words, Sasaki's rule states simply, it's 3 steps. The first step is look at your R wave in what lead? aVR, the forgotten lead. Look at aVR. So is there initial R wave in aVR? If there's an initial R wave in aVR, it's VTach, period. That's a great thing for me as a medic. It's quick, it's easy. I look at aVR. If my first upright deflection there is an R wave, great, bam. It means that it's VTach, right? The whole point of that is that there's a large single R wave in aVR. It indicates that the beat that's originating is propagating from the bottom of the heart up to the top, so that it must be coming from the ventricle. It's coming up to the right arm lead, so it has to be ventricular in nature, right? Well, 97% specificity says yes. All right? But if it's not, then we go to step 2. So if we have a downward deflecting aVR, then we go to step 2. An antiprecordial lead is the interval between the onset of the R wave and the beginning or the nadir of the S wave. Is it greater than or equal to 100 milliseconds? Right? If it is, it's VTach. If no, we go to step 3. All right, that's pretty simple. And then we go to step 3. Initial R wave or Q greater than or equal to 40 milliseconds in any lead. So we're looking for a large R wave or a large Q wave in any lead. If there is, it means that the first 40 or so milliseconds is very slow, and it conducts very slow through the ventricle that you wouldn't expect conducting through the normal electrical conduction fibers like you would expect in an AVNRT or an SVT. If it's greater than or equal to 40 milliseconds, then you can call it VTAC, and it's not SVT. All right, so using those three rules. So going back to our last EKG, all right, we're looking at our rules. It's downward deflecting, no. Then we go to our other rule. We're looking at our point of the R wave to the nadir of my S wave. None of these leads are greater than 100 milliseconds, all right, in my precordium. Then I look at my R wave or my Q wave. None of these are greater than 40. So by definition, this is SVT, according to Sasaki's rule. Let's look at another one. Whoa. You see this. Now, using Sasaki's rule, we know this is a Y complex, but what the hell could be going on here? aVR, downward deflecting R wave. So we go to step 2. All right? These are big R waves. Big R waves. 5, 10, 15, 20, 25, 30. These are big R waves. All right? But using Sasaki's rule, if we count out the millimeters and we count out the nadir from the R wave to the S wave, we find out that this is actually SVT with aberrancy. Pretty cool stuff, huh? Now let's look at this one. Now if you see this, aVR is pointing up. That's the first rule in Sasaki's rule. All right? If it's pointing up, we got VTAC. Bam! You don't have to go anything. You don't have to go anymore. You're done. This is VTAC. Period. All right? aVR is extremely important in diagnosing between VTAC and SVT. All right? So let's do one more. Here's a pre-hospital EKG. Y complex tachycardia. Is this aberrancy? It doesn't say VTAC on our rhythm diagnosis here. It just says wide QRS tachycardia with left axis deviation. We're going to go over all the other criteria with VTAC later. We're just looking at aVR. According to Sasaki's rule, aVR is pointing up. It's got to be VTAC. You don't have to move on. This is VTAC. aVR is very important with that. All right? Some pretty cool stuff, right? So respect aVR. Use it to help you diagnose left main disease. Use it to help you diagnose PE. Dextrocardia, limb lead reversal. We can use it to help us distinguish VTAC and SVT. It's a very good lead to look at, so respect it. Until next time, guys. See ya.